Yesterday we have discussed regarding the management of the shockable rhythm. So, we were discussing the ACLS algorithm, cardiac arrest algorithm. So, we have discussed what are the things that needed to be done when you see a shockable rhythm. So, when you see a shockable rhythm, our priority is to deliver the shock as early as possible. So, the first shock, second shock, and after that only the role of epinephrine will come, and then only we have to give after the third shock only we need to give amiodarone or lidocaine. So that is what we have reviewed in the last class. Now when we come to the other side, so you can see this algorithm, this side of the algorithm is what we are going to discuss today. Okay, so we have come and connected to the defibrillator and seen that it is not a shockable rhythm. So not a shockable rhythm means it is not VF, not pulseless ventricular tachycardia. So it can be either an asystole or it can be a PEA. So PEA, what is PEA? PEA can be any rhythm, so except VF and VT, any rhythm, any organized rhythm, it can look like an organized rhythm because you might be able to see a P wave, a QRS complex and all those things. But when we check for the pulse, there is no palpable pulse. So that is what is meant by PEA. So you will be able to see a rhythm other than VF or VT where there is no palpable pulse. You can call it as an pulseless electrical activity, and if it is a straight line, we can call it as an asystole. So whenever you see an asystole, I told you yesterday, you have to follow certain things. You have to increase the gain and see and zoom it and see whether it is a fine VF or not, whether we are missing a fine VF. The next thing that you need to see whenever you see a straight line, what is the next thing that you need to see? What is the next thing? You have to make sure that the leads are in position. So that's also we have discussed. So in older defibrillator, if the leads are not connected also they will look like this. It will give a straight line. But in the newer defibrillator, it will be like a dotted lines. So if the leads are not connected, it will be a dotted line. So you have to make sure that the leads are connected properly and you have to increase the gain and see whether you are missing a fine VF. So that is the thing that you need to do. So whenever you see it is an asystole or PEA, the first thing that you need to do is what I have said is what you have to immediately continue CPR and put an IV or IO access. See here, so you have confirmed that is this an asystole or a PEA. So the patient had collapsed, unresponsive victim. Okay, unresponsive victim. You have initiated CPR. The next thing is that you have connected a defibrillator and it is a non-shockable rhythm. So non-shockable rhythm, what is the first thing that you need to do? You need to get an IV access and you have to give the drug epinephrine. The dose is again what we discussed yesterday, 1 in 1000 dilution, 1 mg stat with 10 to 20 ml of saline flush. So that is what you have to give and you have to repeat it every 3 to 5 minutes. So that is the most important thing that you need to remember is epinephrine ASAP. They have written it as ASAP. ASAP means as early as possible. So you have to give epinephrine as early as possible. So yesterday we discussed certain things that we have to put an IV access or an IU access. So I told the ideal will be an IV access. If you don't get an IV access, you can go for an IU access also. IU access, you know, there are different anatomical locations where we can do the IO access. The most common thing is the upper end of the tibia. So tibial, just below the tibial tuberosity, medially you will have a small bump here. Just below that, that is the ideal area for an IO access. That we will discuss it in a separate class. But remember that if IV fails twice by a senior person who is well trained, then they can go IO. See, certain times you will not get an IV access or an IO access. So then you are in trouble, right? You are not getting an IV access, you are not getting even an IO access for the patient. Then you are in trouble. So what you have to do? So you have to think that what is the other mechanism by which you need to give the drug, because we want to give the drug. IM and subcutaneous, there will not be any absorption because there is no circulation. Somewhere or other, the drug has to reach the patient. So there are certain drugs that you can deliver via endotracheal tube. Your endotracheal tube. Suppose you have intubated the patient already, or you can intubate the patient, you can give certain drugs via endotracheal tube because it will absorb via the mucous membrane of the lining of the bronchus. So certain drugs you can give. The most important drugs that you can number a mnemonic called as lean. So L is for lignocaine, E is for epinephrine, A is for atropine, and N is for naloxone. So these are the drugs that can be given via endotracheal tube. So suppose you fail to get an IV or an IO access and you are able to intubate the patient, these are the drugs that you can deliver via endotracheal tube. So these are the drugs that you can deliver. Now the thing is that what is the dose that is required? See, when you have a normal thing, you can give 1 mg. But when you are giving it via endotracheal tube, you have to make sure that you are giving 3 to 10 times more. 3 to 10 times more. That is means if you want to give 1 mg, you need to give 3 mg. So thrice the normal dose minimum you need to give. So suppose you have a patient who has collapsed in front of you, you have started CPR and you are able to intubate the patient, you are not able to get an IV or an IU access. It is a non-shockable rhythm. You are continuing CPR. What you can do, you need to give adrenaline. So instead of giving an IM or a sub-Q or an IV or IO, you are not able to get an access, right? So at that time you can give 3 to 10 times the dose. So you can give approximately 3 mg of adrenaline, you dilute, you give to the ET tube and give 10 ml of flush and just bag mask so that it will get absorbed. So that is the procedure that you can do. So certain drugs, which all group of drug as I have mentioned, lignocaine, where will you want to use lignocaine? Lignocaine we can use it for lignocaine or lidocaine, both are the same. Where you can use? You can use for refractory arrhythmia. We can call it as refractory because refractory, what do you mean by refractory? Normally you have done something but it is not happening because you have given shock. Till after giving the shock also the patient is still having arrhythmia. So refractory, if refractory shock means you have given fluid but still there is hypotension. So that is called refractory. So refractory to your treatment, still there is hypotension. So refractory arrhythmias, shockable rhythms, you can give lignocaine. The next thing is epinephrine. Where all you can give epinephrine? Most importantly, it is in cardiac arrest and next is in anaphylaxis. So these are the area where you want to give epinephrine. Atropine, where you will give atropine, the most important indication will be a symptomatic bradycardia. We will discuss that through, but symptomatic bradycardia. So that is the area where you can give atropine, and also in OP poisoning. OP means organophosphorus poisoning. Atropine is the antidote. So lignocaine, epinephrine, atropine. Then we have a drug that is what I told is naloxone. What is naloxone? It is an antidote for opioids. So naloxone. This is the antidote for your opioid overdose. Antidote for your opioid overdose. So that is the drug that you can give. So these are the agents that you can give via your endotracheal tube. Okay. So what we have done, we have a patient who had an asystole or a PEA, which is a non-shockable rhythm. You have started CPR and immediately you can to give epinephrine. So after giving epinephrine, you have to put IV. If you are not able to get an IV or IO access, you can give endotracheal tube. Epinephrine needed to be given every 3 to 5 minutes, and you need to consider an advanced airway and capnography. That is very important. So the most important thing that you need to remember is that advanced airway. What are the options for advanced airway? So when you want to do an advanced airway in a cardiac arrest, see, advanced airway is a priority. I am not saying it is not a priority. Advanced airway needed to be done, but a good backmask ventilation is equivalent to an advanced airway. If you have any doubts, without interrupting the CPR, if you are able to intubate the patient, that is well and good. But prolonged pauses should not be allowed. What will happen? No, somebody, wait, stop CPR, I want to intubate. They will be taking 2-3 minutes to intubate. What is point in intubating a patient who is not having any cardiac activity, or there is going to develop brain hypoxia? There is no point. So the priority is to continue CPR, and without interrupting the CPR, you need to intubate. If so, intubation. If so, interruption, you need to just interrupt while passing the tube. So maybe 10 seconds, not more than that. Without interrupting the CPR, if you are able to do, well and good. But if you are interrupting the CPR, that is not accepted. So without interrupting the CPR, you can go ahead with an advanced airway. Options are, you can have LMA, laryngeal mask airway, where it is a supraglottic, any supraglottic airway device, Tulip's airway, intubating airway. There are a lot of options available. You can either do that, or you can straight away go ahead with an definitely airway, that is your endotracheal tube. So when will be the advanced airway a priority? As I told, advanced airway is a priority when you are dealing with a patient with hypoxic cardiac arrest. So you think that this patient, as I told, a drowning victim. You have rescued a drowning victim and he is in cardiac arrest. Securing his airway is a priority because the hypoxia is a cause for his cardiac arrest, because the water has gone and drowned the lungs, and as a result there is significant hypoxia. So that hypoxia we need to correct. Suppose there is a patient who is having a hypokalemic or hyperkalemic cardiac arrest. That reason is not hypoxia. A back mask ventilation and giving the drugs accordingly is most important. So like that, if you feel that hypoxia is the primary reason, you can go ahead with advanced airway. Or you are not able to do an advanced airway, go ahead with back mask ventilation, and after return of spontaneous circulation also you can go for an advanced airway. So advanced airway, if possible, you can do it, but if not possible, you can just do it after return of spontaneous circulation also. Okay, so most important thing, make sure that the back mask ventilation is done properly. Only thing, one advantage is that when an advanced airway is in place, you can just continue CPR at 100 to 120. There is no need of synchronization of 30:2. Every 6 seconds only you need to give one breath. But otherwise, if there is no advanced airway, after every 30 compression, you need to wait for 2 rescue breaths. Then again, you need to continue. But when an advanced airway is in place, you can just go ahead at a rate of 1 breath every 6 seconds. So 10 breaths in a minute. So that is the thing that you can remember. So CPR quality, what they have mentioned here, the tabular column you see, push hard, that all we have discussed, at least 2 inches or 5 centimeter, and fast 100 to 120, minimize interruptions, avoid excessive ventilation, chain compressor or every 2 minutes or soon if fatigued, that we have already discussed. If no advanced airway, 30:2 is the compression ventilation ratio. And the most important thing that we should have is an end-tidal carbon dioxide monitoring. Suppose you have intubated the patient and already the patient on a ventilator, you have to connect that ETCO2 probe into the patient's back mask end one and to the ET tube, and you should look for the capnography. So capnography will be something like this, So capnography images will be something like this, right? Something like this you will be able to see. So capnography, what is the role of ETCO2 in cardiac arrest? So what are the uses of ETCO2? The first most important use of ETCO2 is that you can confirm the ET2 position. After your intubation, if the ETCO2 is high, you can confirm that the ET is in position. That is not in cardiac arrest. Anytime you are intubating the patient, you can use your ETCO2 and you can confirm the tube position, whether it is in the bronchus. We can confirm by looking at the ETCO2 tracing. So confirming the ET2 position is the role number 1. Then what is the second role? If the ETCO2 is less than 10 mmHg, that means in a cardiac arrest, if the ETCO2, you are continuously monitoring your ETCO2, and if the ETCO2 is less than 10 mmHg, that means your quality of CPR is not good. You need to improve the quality of CPR. Maybe the rate is low, but if you have a feedback device, that is well and good. But if you don't have a feedback device, you have to make sure that if it is less than 10, the quality of CPR, what you are providing is not good. The method, somewhere it is wrong. It is not adequate quality. So that is the most important thing that you can know. The third thing, sudden increase in ETCO2. So you are having a patient with cardiac arrest and you are having something like 15, 16. Now it has become 30, 40. The ETCO2 has increased to 30, 40. So there is a sudden increase of ETCO2. That means this patient has achieved return of spontaneous circulation. So ROSC. So the patient has gotten good pulse. Maybe after 2 minutes when you check for the pulse, that pulse will be palpable. So that is one thing. So what is the first thing? You can confirm the ET2 position. Second thing, if it is less than 10 while doing a cardiac arrest, you can improve the quality of CPR. And third thing, there is a sudden rise in ETCO2. We can see that you have achieved return of spontaneous circulation. And fourth one, if the ETCO2 is persistently low, 10 mmHg, irrespective of your improving the quality of CPR for more than 20 minutes of CPR. So you have been doing CPR for more than 20 minutes and you have confirmed that you are doing a good quality of CPR, but still the ETCO2 is less than 10, the chance of revival or return of spontaneous circulation is very low and you can consider stopping doing the CPR. So this is what I discussed yesterday, when to stop CPR. So when to stop CPR, one thing is that when you have got return of spontaneous circulation, or the provider get exhausted, or if the ETCO2 is persistently low, even after you have given a good quality CPR, even after that the ETCO2 is persistently low, that is less than 10 mmHg for more than 20 minutes you have given CPR, that means the chances of return of spontaneous circulation is very low and you can consider stopping CPR. So these are the uses of your end-tidal carbon dioxide. So this will be a short note for you. So you have to be very clear. So what are the uses of ETCO2? One is to confirm the position of ETCO2, confirm the position of endotracheal tube. Second, to know the quality of CPR. Third one, return of spontaneous circulation, sudden rise of ETCO2. And ETCO2 if persistently low, less than 10 mmHg, you can think for more than 20 minutes, you can think of considering stopping the CPR. So these are the uses of ETCO2 in a case of a cardiac arrest or anywhere you can discuss all those things. Okay. See, another thing is that if the patient is having a normal lung, so suppose you have a patient with COPD, right? So COPD, what can happen? They can have carbon dioxide retention. So ETCO2 and PCO2 has got an association. It is not equal, it is almost equal. It is plus or minus 5. So suppose the ETCO2 is around 40, the PCO2 will be around 40 plus or minus 5. 40 plus or minus 5. So what is the advantage that suppose a patient is on a BiPAP. Okay. So rather than taking an ABG always, you can just put an ETCO2 monitor. Maybe you can connect to the nasal prong. There is another interface also. One interface what you have seen is connecting to the ET tube. There is another interface of ETCO2 where you can connect to the nasal prongs. Suppose the patient is breathing via normally or via BiPAP, you can connect this interface to the nasal prongs. Just like a nasal prongs, you will get that interface. Rather than you will get something like this, no, like a tube for connecting your ETCO2 to an endotracheal tube. Instead of that, you will get something like a nasal prongs. You will have one opening here, one opening here, that you can connect to the patient. So there are two interfaces available. So if you connect that, the ETCO2 will be, if the patient has got no other pneumonia or anything, if the otherwise it's a stable patient, the ETCO2 and PCO2 will have a correlation. So we don't need to prick for an ABG very frequently. So that is one additional advantage that we can use in continuous monitoring of ETCO2 in a critically ill patient. If you have a continuous ETCO2 monitoring, you need not prick for an ABG always to see the PCO2. But PO2, if you want to know the PO2, definitely you want an ABG. So that is another additional advantage of having an ETCO2. So we will come back to our resuscitation. So what we have done, we have continued the CPR. We are given epinephrine every 3 to 5 minutes. That is the only thing that you need to do in here. So there is no other drug involved in a non-shockable rhythm. In a non-shockable rhythm, there is only one drug that you need to remember, that is epinephrine. Every 3 to 5 minutes, you need to continue giving epinephrine till return of spontaneous circulation is achieved, or else you have a less ETCO2. If it is ETCO2 is very low and you are planning to stop CPR, you can consider that. So that is the algorithm that you need to remember. So rhythm is shockable. No, see what we have done, we have started with no shockable rhythm. So continued CPR, every 3 to 5 minutes you are giving epinephrine. Then again after 2 minutes you reassess. If it is a shockable rhythm, go to this side. Go to this side. If it is a shockable rhythm, what you have to do? Deliver the shock. See, as I told yesterday, you can have initially to start with a shockable rhythm, then you can go to a non-shockable rhythm. Initially a non-shockable rhythm, then to a shockable rhythm. So whenever you see a shockable rhythm, what is the idea? Deliver the shock. If it is a non-shockable rhythm, continue CPR and every 3 to 5 minutes you give epinephrine. So after third shock, if the patient is not improving, what do you have to give? You have to give amiodarone or lidocaine. That is the only difference. So epinephrine is there on both the sides. But only difference is that suppose initially you are seeing shockable rhythm, there is no role of initial epinephrine. Only after 2 shocks you need to give epinephrine. Suppose you are seeing a non-shockable rhythm, the role is to give epinephrine as early as possible. So immediately you have to give epinephrine. That is the only difference. And after 2 shocks, if the patient is still refractory to the shock, you can give amiodarone or lidocaine. So after giving that, if still it is on refractory, what you can give? You can give half the dose. Whatever 300 mg, you can repeat 150 mg. If it is lidocaine, you can give 0.75 to 0.5 to 0.75 mg. So that is the difference. So that is what you have to remember. So whenever you see a shockable rhythm, our aim is to give epinephrine as early as possible. Sorry, whenever you see a non-shockable rhythm, when you see a shockable rhythm, our aim is to defibrillate the patient. So that is the only thing that you need to remember. So 2 shocks, not improving, give drugs. Non-shockable rhythm, continue CPR and you give epinephrine every 3 to 5 minutes and make sure that you are doing good quality of CPR. And meanwhile, you look for reversible causes of cardiac arrest. So that is the time when you need to ask for a blood gas analysis. So while doing the compression, you need to have a team dynamics. As I told you, you should have a team dynamics and you should have sharing of information. You have to discuss within the team. You have to always remember that you have to look for a reversible causes. Why this patient is having a cardiac arrest? What are the reversible causes which I can treat immediately? Maybe it's a hyperkalemic cardiac arrest. You can give and calcium gluconate or soda bicarbonate. So depending upon the cause of cardiac arrest, the treatment will be decided further. So these are the 5 H's and 5 T's of cardiac arrest that you need to remember. So you have to look for hypovolemia, hypoxia, hydrogen ion, hypo or hyperkalemia and hypothermia. So these are the H's that you need to remember. 5 H's of cardiac arrest. Then you have T's is tension pneumothorax. We have already said what is tension pneumothorax. Then we have the cardiac tamponade. Cardiac tamponade, that is the next thing. Then toxins. The patient had consumed any toxins, that will be the other causes. Then it is thrombosis, both coronary and pulmonary thrombosis. So you have to think what is the reason why this patient is having a cardiac arrest. So we have to go for the 5 H's and 5 T. Now, how will you decide this 5 H's and 5 T? I will say tomorrow. We will discuss that tomorrow. How will you find out? What are the clues that this patient is probably having a hypovolemic cardiac arrest? What are the clues that it is a hypoxic cardiac arrest? How will you differentiate? How will you identify this? For a patient with cardiac arrest, how will you identify? It is very difficult because you don't might get any history. Only investigation that will be helping is a blood gas analysis. One blood gas analysis will let you know whether there is any hyperkalemia, hypokalemia or acidosis. That is only information. So you can check for the core temperature. Hypothermia is the temperature you can check. If there is a hypothermic cardiac arrest, you need to rewarm the patient. So these are the only thing that we will be able to know. So how to identify this, I will discuss it tomorrow. So just for the time being, you remember these are the 5 H's and 5 T's of cardiac arrest for a non-shockable or a shockable. Whichever be this, these are the causes for cardiac arrest, reversible causes of cardiac arrest. So in a nutshell, we have completed this algorithm. So you have to remember that what we have discussed today. We have a patient who had collapsed. We have called for help. You have started high quality CPR and meanwhile a defibrillator has come. You have connected and seen whether it's a shockable or a non-shockable rhythm. If it is a non-shockable rhythm, what do you have to do? You have to give epinephrine as early as possible. So get an IV access or an IO access, or if not possible, you can think giving endotracheal tube also. The next thing what you need to do is that you have to every 3 to 5 minutes you need to give epinephrine and you have to look for the reversible cause of cardiac arrest. So whenever you have got a reversible cause of cardiac arrest, you have to treat that also. And after 2 minutes, suppose I am giving an option that after 2 minutes you are seeing some organized rhythm, okay, but there is no palpable pulse. What will you do? So after 2 minutes, initially it was an asystole, okay, so you started compression, 2 minutes over. Now when you are connecting to the defibrillator, you are seeing some organized rhythm, but there is no palpable pulse. So what is it? PEA. It is PEA, pulseless electrical activity. So for PEA, what you should do? Continue CPR. So after whatever rhythm you see, you are not considering. But whether it is a shockable rhythm, you have to deliver a shock. But we are seeing an organized rhythm. Next important thing that you see, check for the pulse. There is no pulse, continue CPR. Then after 2 minutes, you reassess and every 3 to 5 minutes, you continue giving epinephrine. After 2 minutes, there is a sudden increase of ETCO2. ETCO2 was 50, now it has increased 30. And there is a palpable pulse. So what do you have to do? You have to stop CPR and you have to go for post cardiac arrest care. So that will be in the coming classes. We will discuss what are the important components of a post cardiac arrest care. So it's very clear. Now on to this side, shockable rhythm. We have discussed this yesterday. Shockable rhythm, what you have to do? We have to immediately defibrillate the patient. Amount of energy 200 joules or maximum energy whatever is available. 1 shock, 2 shock, reassess, 3rd shock you have to give. After that you have to give amiodarone or lidocaine and again you look for the reversible causes of cardiac arrest. So this is the algorithm, very important algorithm. You have to be very thorough because this is going to be the most important algorithm for all your throughout your career. So wherever you go for any interview or any patient care, this is the most important thing that you need to remember. So there is no point in forgetting this. So the most important algorithm that you need to remember is this algorithm. And very few drugs only what we need to remember. And one more drug that I will add on, which is not in this algorithm. I'll just show one rhythm. You have to tell me what is this rhythm. And I will tell the treatment for that after you telling me what is the rhythm. What is this? Polymorphic ventricular tachycardia, or otherwise it can be called as torsade. Torsadis pointus. So what is the drug of choice for torsadis pointus? The drug of choice is magnesium sulfate. Magnesium sulfate 2 to 3 gram IV stat. So that is the drug of choice for your torsadis pointus. So when you see a torsadis pointus, the drug of choice is magnesium sulfate. So that is what you need to remember. So that is the additional thing which is not given in this algorithm, but in AHA it is already there, but they have not written in this algorithm. So drug of choice for your torsade is magnesium sulfate. So whenever you see this torsade, what you have to do? You have to shock and you have to give magnesium sulfate also. That is the additional thing that you need to remember. Clear? Okay.